Hi everyone, Sam Marie here again from Right at Home. Today we have the privilege of being here with Dr. UK Quang-Dang. She's a geriatric psychiatrist and she has just presented at the V in our 8th session of the Navigating Dementia series. I wanted to give the audience an opportunity to also learn from what the members here did get to hear. So first of all, let us welcome you.
Hello. Hi.
Thank you. Hi. UK, let me first start with the very basics of questions. When we say the 3 Ds of aging, dementia, delirium, depression, can you just give us a quick overlay, like a one-line sentence of what are these terms?
Oh gosh, it's really hard because they are really complicated diagnoses or conditions, but I'll do my best. So let's start with dementia. That's something that I think we all probably are familiar with. Dementia is a loss of cognitive ability, and the loss of cognitive ability has led to a loss of function in life. And that's important. There's many of us who walk around with, we forget this, we forget that. We're go into a room and we don't remember what we went in for, but it doesn't affect our day-to-day abilities. When it starts to affect it, that's when it's dementia. And then for depression, that is a distinct shift in mood to a low depressed state or irritability, and also a lack of ability to enjoy things.
Right.
Then lastly, delirium is the most confusing. Delirium is a medical condition where there's an acute brain failure, where there's a physical condition such as a urinary tract infection or a upper respiratory infection like a pneumonia that affects the brain. And the symptoms are basically a sudden change in mental status, confusion, and possibly hallucinations.
So they're all very different, but they all have some kind of impact, similar kind of outcomes that we see. How do families start if they want to know what is the right diagnosis? Where should be the first kind of clue? If you talked about today being a detective, what should be the first kind of clue that we look for to differentiate between the 3?
Okay.
They may present themselves similarly, right? But I think that is the biggest challenge because they do present themselves similarly, but each of them has much more severe consequences than the other. So what do you do?
I would say, as a family member of a loved one who has any of these symptoms, I would ask myself, when did it start? Did it start a week ago? Did the symptoms start a month ago or a year ago? How long has this been going on for? The most important one to detect is delirium because it is considered a medical emergency. With delirium, you want to get it treated right away so that the delirium can go away, but also the primary cause of the delirium is treated, the urinary tract infection or the upper respiratory infection. So you ask yourself, my dad is behaving differently. When did this start? And if the answer is it started the last few hours or overnight or a few days ago, then you should have your index of suspicion to be high for delirium.
Right. But you were saying that so many conditions, like people when they're in the hospital, but 50% of them face some sort of delirium, is that correct?
Yes.
Then why is it not?
It can be up to 50%.
Why isn't it recognized more easily, more frequently, if it's such a common phenomena?
I think it's a number of things. One, when we get older, a lot of things change, right? And I think family members and friends have a hard time figuring out, is this just part of the aging process? Oh, they're more confused. And is this really something bad going on, or is it just they're 90 years old? There's also the ego factor. Maybe that's a good way to put it, an ego factor where we don't want to insult our husband or wife or our parent and say, you're not acting the same, or you're behaving differently, something's off. That is a very hard thing to be able to bring up. So I think people kind of avoid talking about things they notice until it becomes a big problem.
Right.
And then by then, things have progressed and maybe it's harder to treat and things like that. And what else? I think those are probably the two main things. And I think actually the third one is that for psychological or psychiatric symptoms, we usually don't think that there's a physical condition to be treated.
Right.
We think, oh, they're having a bad day.
Yeah.
Oh, something happened that got them angry or irritated. They got into an argument. But we don't think, they might be dehydrated.
Right.
They might not have drank enough water, or they might have a stomach bug, or a UTI or a URI.
Right.
We don't connect the psychiatric and the body as much. But in geriatrics, the two become much more, there's a huge overlap, and the two become one, so to speak.
But I love that having professionals like you're able to connect those dots together for so many families. You really are a resource for families. One thing I found really interesting during your talk, you said a lot of things are not problems of memory or dementia, but they're problems of attention.
Yes.
I thought that is so wise and just something we overlook a lot.
Yeah.
But there's a lot of things that we may not pay attention to. How do you kind of differentiate for that, knowing when to dig deeper? Is it attention or is it dementia?
I think the time between the information is given and the time when the information should be retrieved, that time lag is important to look at.
Yeah.
So, like the example I gave in the lecture, this patient, Laura, her son would teach her how to use something, the remote, press power, up and down, and literally within minutes, under 5 minutes, she would ask again.
Yeah.
That could happen in late stage dementia. Yes, that could happen in late stage dementia. But in early stage dementia, they're not going to be asking over and over like that. It's more like they're taught it, and then maybe like 30 minutes or an hour or 2 hours. In early stage dementia, more like hours, they ask again.
Yeah.
But in delirium, where the problem is much more of attention, they weren't paying attention, they weren't able to pay attention in the first place.
Right.
So the information never got in, the problem is still there, so they keep asking.
Yeah.
And they keep trying to figure it out.
But I think even in general, like many things in my life, I don't remember just because I've not paid attention. How do you know it is actually an issue, or is it just because I've not paid enough attention?
Okay. So that's a good question.
Because I think most people would relate to that. So all of our attention spans are decreasing, being on the phone, social media, whatever.
Yeah, yeah.
You know?
There's something called salience in psychology or neurology, but salience is how important something is. Yeah. So I think it's really important to weigh that. If something important is something that, if it's something like anniversary date or somebody's cancer diagnosis or something like that, that it's emotionally impactful.
Yeah.
And then you forget that is very different from forgetting the date of something that's, a doctor's appointment.
Right.
Because that's not as salient.
Yeah.
So the more salient the content is, the more likely it is for you to remember it.
Right.
If you're not remembering really emotionally important things, I think that's more of a problem.
So tell me, what is a red flag where families should know to reach out to a resource like you? What is normal everyday aging, and what is something where families should say maybe it's time to seek some guidance of a professional like you?
Yeah. So normal aging has a very expected process that happens, which is slower processing speed. The information is there in the brain, but it just takes more and longer to retrieve that information.
Right.
So that's why older adults are not like quick, and,
Right.
in responding. But given enough time, they can give a really solid answer, and they can really formulate complicated responses,
Right.
nuanced responses. But it takes time. So processing speed is one area that it's known to slow down. So that's okay.
Right.
Another is set shifting. Set shifting is harder for older adults. So if they are engaged in one activity and then expect to do something else, that's going to be harder.
Right.
So the fewer transitions, the better. What would be so those are normal. What would be red flags would be, like we mentioned, forgetting important things.
Right.
And there's so many red flags based on what diagnosis we're talking about. Something that would be a red flag for me is lack of insight. So what that means is the patient themselves are not understanding the gravity of their situation. A woman came in and her husband brought her in and said, she is drinking every night. She used to never ever drink alcohol. She's drinking every night, and she's having huge, terrible temper tantrums. The woman hears all this, and she gives excuses. I have a good reason. My granddaughter keeps leaving the door open, et cetera, et cetera. And I asked her what she thought of her drinking, and she said, no, just very laissez-faire about it, not a big deal. And then I brought her attention to that. I said, she was obviously a very smart woman. Your husband, who you've been married to for 50 years, is so worried about you, bringing up this unusual behavior of drinking, and yet hearing all of this, you don't look at all distressed.
Right.
So there's the lack of insight into the gravity of the situation. That is worrisome. It turned out that I recommended her get a brain imaging, and she had a brain tumor in her frontal lobe the size of a lemon. That was non-cancerous and was resectable. So, those are different red flags when things just don't make sense, and if the patient whether the patient sees it as a problem or not. That tells me a lot.
So tell me, when should we be getting diagnostic testing? It could be just for dementia, could be for brain scans.
Yeah.
What kind of diagnostic testing should we be getting, and when? So we don't feel like we're always like under a gun.
Yeah. This is a little bit of a controversial idea, but I personally would recommend for my friends and family, if they can afford it, to get neuropsychological testing at baseline when things aren't bad, when there isn't yet a problem. The reason for that is then if you do have an issue later on cognitively, when you get tested at that time, you have your own baseline to compare it against. And you can see, my executive functioning was at this score, and now it's lower. And it's important to do it because otherwise you're comparing your test results to the whole population, and it's not specific to you. And so you don't, and a lot of people who have higher education, their scores are high anyway. So it looks like they have normal scores or even high scores, but they themselves know that something's different. But it's almost impossible to tell without the previous testing. The other thing is, brain health is heart health. So all the things we do to protect our heart is also things that we should do to protect our brain.
That's interesting.
Our cholesterol level, our blood sugar level, how impacted our arteries are, everything that's going on here, they're the same blood vessels that are up in the brain. But somehow we've divided it up and said cardiovascular health is actually heart and brain health. Well, it's all the organs, So I think getting really good checkups for your labs in terms of cholesterol and sugar, making sure you don't have pre-diabetes, things like that, is important.
Are there any important studies that show innovations for dementia, for depression, for delirium, or where are we on that?
Okay, for delirium, unfortunately, there aren't any groundbreaking things that we're still using, different treatments that we've used for a long time. There is research on things that patients can take before a surgery to reduce the risk of delirium.
What would that be?
I'm trying to remember. I don't want to misspeak, but there are some very common things that can be given. And that's to reduce the risk, not to treat.
Right.
And then for depression, the world of interventional psychiatry is becoming much more robust. What is interventional psychiatry? It's basically machines like transcranial magnetic stimulation, transcranial electrical stimulation, nasal sprays. So that's a little bit more like medicine, but it's still a different formulation. So esketamine nasal sprays. So there's a lot in psychiatry that can affect the brain in treating depression. TMS, transcranial magnetic stimulation, is actually shown to be quite effective. In my everyday work, I'm not really sure I see it as that effective, but the data and the big research studies do show that it's really effective. And there's a great TMS center here at Stanford. And then for dementia, unfortunately, there's not that many well-established treatments, but there are new treatments that were FDA approved last year and this year that are IV infusions that are antibodies to the amyloid plaques that can reverse some of the signs of Alzheimer's. But you have to meet strict criteria to be able to get the treatment because there's so many risks involved.
Oh my God, UK, I just love it. I feel like you can answer so many questions all of us sit with and worry about and just want to know more about. How did you get into geriatric psychiatry, such a specific niche?
Yeah.
How did you find it, or did it find you?
Well, I sort of knew I was going to become a psychiatrist because my parents are both psychiatrists. My mom is a psychiatrist. She always says that the one good thing that came out of the Vietnam War was that when she was a medical student in Vietnam, she had not heard about psychiatry as a profession. And it wasn't until she had to flee Vietnam and come to the United States that she learned about psychiatry, and that was really her calling. My stepdad was a professor of many years at UCSF, also of psychiatry. And my mom did community psychiatry. My stepdad did academic psychiatry. The bottom line is that they were both very happy.
Which is
very
best reason to mimic them, right?
Yeah. It was totally different ways of doing psychiatry. One's very research-based in the hospital setting, one in the community, seeing like 30 patients a day, trying to help everyone that she was seeing, very real life. And they were both really happy. So I knew there was something there for me if I wanted to pursue a niche in psychiatry. I also love thinking about how people work, what makes people tick. And one of the things I treasure most in life is connection with others. So those are different things that made me feel like, okay, I have a calling for psychiatry. I did try other paths like urology, surgery, geriatric medicine, but psychiatry was really what I felt I fit the best with. In terms of why geriatrics, while my parents were in school and working full-time, overtime, when I was a kid, my grandmother was the one who raised my brother and me. We all lived together, my parents and maternal grandmother, and I think through just being around her, my brother and I were both just so comfortable being around older adults and feel a real connection. Yeah, I'm very much in a flow state when I'm with older adults that I don't find myself being in when I'm with kids or middle-aged people.
But that's so inspiring, really. I feel that meaning of family and connection, it resonates with everyone. And that's exactly what you want in a doctor that you're looking for to find solutions with. We're in the business of problem solving, right?
Yes. Yeah, geriatric psychiatry is all about being detectives, getting in the weeds, and problem solving. Yeah, for sure. And I love doing that. I love getting in the weeds and learning about all the little details. Because as we get older, these little details make a bigger and bigger impact, or can make a bigger and bigger
But tell me, UK, now, if families want to learn more, or they want to meet you or organize some kind of further intervention, what's the best way to get a hold of you?
I think the best way, I put a lot of time into my website to explain what it is that I do. and the way that I work.
Okay.
So one thing so the website would be a good place to start. But I want to emphasize I don't enjoy and thus I don't see patients who just want pure medication management.
Right.
I am much more. I'm much better at my job of helping people when I get to know about a person's whole life.
Holistic approach.
Holistic
right?
approach, yeah. So my website is www.qdmd.com.
Thank you so much, UK. This has been very meaningful, getting to know you, getting to learn from you, and being able to bring your resource to the community as well.
Thank you so much,
thank
Anne-Marie.
you so much.